Okay, good evening and welcome. My name is Isha Vadir, and I'm thrilled to be your moderator and your first speaker for today's webinar, From Stigma to Support, Changing the Dementia Narrative. Before we dive in, I want to take a brief moment to give a massive thank you to our lecturer, Dr. Amias Terefe. Dr. Amias, your mentorship and motivation have truly inspired us to step up as digital health communicators, and this webinar is a direct result of that encouragement. Thank you for pushing us to share our clinical knowledge beyond the classroom. Today, I am joined by an incredible panel of speakers. They'll switch on their cameras also. Bernice Jagi, Arthur Lusanji, and Chisom Mary Eku. And this is me. Hi. So to avoid some clinical to avoid some technical issues, we'll just switch off our videos during the presentation and we'll switch them back on at the end. Okay, so let's begin. To start, we need to clearly define what we're dealing with. Dementia isn't actually a single disease. It's an umbrella term used to describe a set of clinical symptoms. It represents a clinical syndrome caused by the progressive impairment of cognitive functions. So, as you can see, this syndrome impacts memory, perception, reasoning, attention, and language. Ultimately, this cognitive decline becomes severe enough that it actively interferes with a person's normal daily functioning, judgment, and their ability to live independently. Patients may begin struggling with activities such as managing finances, remembering appointments, recognizing familiar environments, or even performing self-care. Another key point is that dementia should not be considered a normal consequence of aging. Although aging increases risk, dementia occurs because of underlying pathological processes affecting the brain. Among all causes of dementia, Alzheimer's disease is the most common, accounting for approximately 60 to 70% of cases globally. So as I mentioned, Alzheimer's. So this is a cross-section of the brain, and its physical toll is really severe in Alzheimer's disease. A normal brain has plump cerebral cortex folds and a healthy hippocampus, as you can see here. But in severe Alzheimer's, we see extreme shrinkage of the cerebral cortex, severely enlarged ventricles, as we see here, and extreme shrinkage of the hippocampus, the very area responsible for forming new memories. Now, one of the most common questions that we all wonder is this just normal aging? It is crucial to distinguish between the two. Normal aging might mean occasionally forgetting a name or misplacing items, but you remember them later and it doesn't significantly affect your independence. Now, dementia, on the other hand, involves frequently forgetting recent events, a progressive decline in daily functioning, and significant impairment in decision-making that prevents the patient from performing familiar tasks independently. Healthy older individuals generally remain independent and can perform their normal activities, even if they require occasional reminders. Individuals with dementia progressively lose the ability to manage medications finances, household activities, and eventually basic self-care. So as I mentioned previously, Alzheimer's is the most common type of dementia, which is characterized by amyloid plaques and tau tangles. But it's not the only type. We also see vascular dementia, often resulting from strokes or reduced cerebral blood flow. There is dementia with Lewy bodies, characterized by visual hallucinations and Parkinsonian motor symptoms. And lastly, we also have the frontotemporal dementia, which mainly degenerates the frontal and temporal, which are the side lobes of the brain, which brings early behavioral and personality changes. And there's also mixed dementia, which is commonly a combination of Alzheimer's and vascular dementia. Now, the global burden of this syndrome is immense. Right now, there are over 55 million people worldwide living with dementia. What's particularly relevant for us is the distribution that approximately 60% of these cases occur in low and middle income countries. And the economic impact is staggering, with global costs exceeding $1 trillion annually when factoring in healthcare, long-term care, and lost productivity. So, who is at risk? We can categorize risk factors into two buckets: non-modifiable and modifiable. We cannot change advanced age, genetic predispositions, or gender. Females have a higher risk partially due to longer life expectancy. However, we can target the modifiable factors, the ones that can be changed. These include managing hypertension, diabetes, and cardiovascular disease, as well as counseling patients on smoking cessation, alcohol consumption, obesity, and physical inactivity. Now, before I hand it over to my colleague, let's briefly look at the cellular level. Now, let's start with what a healthy brain does. So picture the brain as a huge city with billions of residents, which are the neurons, constantly sending messages to each other through tiny wires, which are the nerve connections, using chemical signals. This is how we think, remember, move, and feel. So what goes wrong in dementia? So dementia isn't one disease, as I mentioned. It's an umbrella term for what happens when brain cells get damaged and die faster as they should. And the connections between them break down. So as more cells are lost, the city starts losing services. Memory, judgment, language, and daily functioning slowly shuts down. So here's what happens in all the different types of dementia. So in the Alzheimer's, which is the most common type, so think of it as a garbage disposal problem. So think of healthy neurons as needing regular garbage collection. In Alzheimer's, two things go wrong. Sticky clumps, called plaques, build up between brain cells made up of a protein called amyloid. And twisted tangles form inside brain cells, made of a protein called tau. Both of these gum up the works. Cells can't communicate properly, and eventually they die. This tends to start in the memory center, which is the hippocampus first, which is why memory loss is usually the first sign in Alzheimer's disease. Next, we have the vascular dementia. Think of it as a plumbing problem. So the brain needs constant blood flow to deliver oxygen and nutrients. If small strokes or blocked blood vessels cut off blood supply to parts of the brain, those areas get starved and die off. So it's less about garbage buildup and more about the pipes getting clogged. The third one is the Lewy body dementia. A similar clumping problem, but a different location. So here, A different protein called alpha-synuclein clumps up inside cells, especially in areas that control movement, alertness, and visual processing, which is why this type often comes with hallucinations and movement issues alongside memory changes. And lastly, we have the frontotemporal dementia. So this type targets the front and side parts of the brain responsible for personality, behavior, and language. So changes in behavior often show up before memory problems do. Now, what's the end result? So whatever the specific mechanism, whether it's Alzheimer's, vascular, or Lewy body, the end result is always the same: fewer working neurons, weaker connections between them, and a gradual shrinkage of the brain tissue. Now, the big question is, how do we fight back? To answer that, I am thrilled to introduce our next speaker, Bernice Jaggi. Bernice is going to bridge the gap between pathology and pharmacology. She will break down the classification of anti-dementia drugs and give us a comprehensive look at our first-line pharmacological defense, the acetylcholinesterase inhibitors. Bernice, the floor is yours.
Thank you so much, Isha, for the amazing introduction into dementia. And thank you everyone for joining in. So I'll be taking you through the medications used in dementia. So to begin with, as Isha mentioned, dementia is not curable. However, we strive to manage the symptoms. So the goal here is symptomatic relief. So the therapeutic aims is to improve cognition and memory, to slow functional decline, and to improve the quality of life of the patient. So early treatment is very critical to achieve better symptom control. Next, Isha. So I'll take you through the classes of anti-dementia drugs. So the first class, we have acetylcholinesterase inhibitors, such as donepezil, rivastigmine, and galantamine. So for this class of drugs, they increase acetylcholine neurotransmission by preventing the breakdown of acetylcholine by the enzyme acetylcholinesterase. So here, we use these drugs in mild to moderate Alzheimer's disease. Next, we have the second class, NMDA receptor antagonists such as memantine, which will be further discussed by the next presenter. But the basic mechanism of action here is to reduce glutamate-mediated excitotoxicity. So this drug can be paired with donepezil in a fixed dose combination, and we also use it in moderate to severe Alzheimer's disease. Next, we have DMTs, which are disease-modifying therapies. It's an emerging paradigm. So here we have the use of anti-amyloid monoclonal antibodies, such as aducanumab, lecanemab, and donanemab. So these antibodies, they target the beta amyloid pathology, the plaques that Isha mentioned previously, and they help to slow disease progression. Next, we have drugs for behavioral and psychological symptoms, BPSD, such as antidepressants, antipsychotics, anxiolytics, and sleep agents. So here we target depression, signs of agitation and psychosis, anxiety, and sleep disturbances. So here the goal is to improve behavioral symptoms and the general quality of life. So this is the current treatment landscape. And as I mentioned, the disease-modifying therapies is mainly what we have under the emerging paradigms. So a deeper dive into acetylcholinesterase inhibitors. So these are the first-line drugs for Alzheimer's disease. So acetylcholinesterase inhibitors, the examples we have here are donepezil, rivastigmine, and galantamine. So how they work is that in Alzheimer's disease, as Isha mentioned, we have loss of cholinergic neurons, and this leads to reduced amounts of acetylcholine, We have, so these drugs work by inhibiting acetylcholinesterase, and this results in increased acetylcholine availability at the synaptic junctions, leading to improved cognitive function. So generally, in Alzheimer, we have loss of cholinergic neurons and decreased levels of acetylcholine. So these drugs inhibit that enzyme and increase the levels of acetylcholine, improving cognition and memory, attention, and daily functioning of the patient. It also results in temporary symptom stabilization. The limitations of these drugs, this class of drugs, is that they are not curative. They merely provide symptomatic benefit and they do not reverse neuronal loss. A key point, which I already mentioned, is acetylcholinesterase inhibitors increase acetylcholine levels, and this is their primary mechanism of action. Next. So this is just a comparison of the different drugs. Something to note is something that stands out for each of these drugs is for donepezil. This is the most commonly prescribed drug with the longest half-life of about 70 hours. Rivastigmine stands out because it can be administered as a patch, and this helps with patients struggling with adherence. It is the preferred option. Galantamine, it offers an additional nicotinic receptor enhancement, and it works the fastest. Next. So just a few clinical pulse for these drugs. So the greatest benefit, as I mentioned, occurs in mild to moderate Alzheimer's disease, and early initiation of treatment helps to preserve cognitive function. However, it is important to note that individual response varies from person to person. A clinical pearl to note is that we start from low doses and titrate upwards, and GI are the most common adverse effects during this dose escalation. It is important to monitor heart rate as there's a risk of bradycardia. Bradycardia is slow heart rate. It is also important to monitor body weight and nutrition and cognitive function. It's also important to assess adherence and tolerability by the patient. Where the drug is not tolerable, you can switch to another class of drug. Thank you. Isha, back to you.
Wow. Thank you, Bernice. Thank you, Bernice, for such a clear and practical overview of acetylcholinesterase inhibitors. It's a great reminder that starting low and going slow is the key in our clinical practice. Next up, we are dividing into the cutting edge of dementia care with Arthur Lusenji. Arthur will begin by walking us through memantine, the first NMDA receptor antagonist approved for Alzheimer's disease. But what I'm particularly excited for you all to hear in his breakdown of the new era of disease-modifying therapies, or the DMTs. Finally, he will touch on managing the behavioral and psychological symptoms of dementia, ensuring we treat the whole patient, not just the symptoms. Over to you, Arthur.
Thank you very much, Isha. I'll be taking you through memantine as we move on through this presentation. So I'll be introducing you to another important medicine for Alzheimer's that is called memantine. So unlike the previous medicines, memantine works in a very completely different way. And so instead of acting on the acetylcholine, it acts on another chemical messenger in the brain called the glutamate. So this glutamate is very important because it helps the brain cells communicate with one another. So it is essential for learning, memory, and even the normal brain function. However, in Alzheimer's disease, there's often too much glutamate activity. So when this happens, the brain cells become very overstimulated. As you can imagine, pressing the accelerator of a car all the way down for many hours, you can damage your engine. So in a similar way, when we have very excess glutamate, we are overstimulating our brain cells, and we are causing calcium to enter the cells in very large amounts. And so this will lead to something we call excitotoxicity. So this is where the neurons will become injured and can eventually die. So memantine blocks this excessive stimulation while still allowing for the normal communication between the brain cells. So in other words, it protects healthy neurons from the unnecessary damage without shutting down normal brain function. That is why memantine is known as an NMDA receptor antagonist. And importantly, it is currently the only approved medicine in this class for Alzheimer's disease. Clinically, memantine is mainly prescribed for people with moderate to severe Alzheimer's disease, and it can also be used together with the acetylcholinesterase inhibitors like donepezil, because the two medicines work through different pathways and can complement each other. So if you have ever visited a pharmacy, you may have recognized memantine under brand names such as Ebixa, Amanda, or Memixa. And so one important point I'd like just everyone to remember is that memantine is not a cure for dementia, and it cannot reverse the damage that has already occurred. But it helps in maintaining, improving daily function and also maintaining the quality of life for the patients. So while memantine offers these important benefits, like every medicine, it also has the potential side effects and precautions. So let's just look at its safety profile. So overall, memantine is considered to be one of the better tolerated medicines with Alzheimer's. So in fact, even when we compare it to the cholinesterase inhibitors like donepezil or rivastigmine, it will generally cause fewer stomach-related side effects, which many patients appreciate. Looking at the first column here, you can see the most common side effects may include dizziness, headaches, drowsiness, or somnolence, confusion, fatigue, constipation, and even sometimes patients may have problems with walking or balance, which we call it as gait disturbances. A small number of patients may have increased blood pressure or hallucinations. Here you can also see the contraindications and the cautions you need to have when you are using these medicines. For example, anyone who has previously had an allergic reaction to the medicine should not receive it. You also need to be very careful in patients who have severe heart disease, a history of seizures, uncontrolled hypertension, severe kidney disease, or conditions that make the urine more alkaline, as this may affect how the drug is cleared and eliminated from the body. Now let's look at the drug interactions in the third column here. We have amantadine, which is sometimes used in Parkinson's disease, may increase the risk of neurological side effects. Ketamine is an aesthetic and can have additive effects on the NMDA receptors. We also have the drug dextromethorphan, which is found in very many cough syrups, and it may increase the CNS system side effects when taken together with memantine. And also medicines such as acetazolamide or even the regular use of sodium bicarbonate can make the urine more alkaline, and this slows the removal of the memantine from the body. And so it can lead to increased drug levels, and there is increased risk of the drug adverse effects. Finally, as you can see here, the monitoring parameters, which is important for caregivers as well as healthcare professionals. When someone is taking memantine, we need to regularly assess the cognitive functions using tests such as the mini mental state examinations or the Montreal cognitive assessments. You need to also be monitoring for any dizziness, confusions, blood pressure, regular checks. Kidney function should also be reviewed because this drug is usually cleared by the kidneys. And of course, we also always assess so that the patient is taking the medicine correctly and benefiting from it. Now that we have covered the main asymptomatic treatments for Alzheimer's disease, I'd like to introduce you to a new generations of medicines that are changing the way we think about this treatment. So these medicines are known as disease-modifying therapies. As the name suggests, these medicines are designed to target the underlying disease process rather than just simply treating the symptoms. One of the key abnormalities in Alzheimer's disease is the buildup of a protein called beta amyloid. This protein gradually forms sticky deposits known as amyloid plaques between the brain cells. These plaques will interfere with communication between neurons and trigger inflammation. and eventually contribute to the death of brain cells. So the newer medicines shown on these slides are called anti-amyloid monoclonal bodies, and they're laboratory-produced antibodies that are specifically designed to recognize and attach to these abnormal proteins. Once attached, they will signal the body's immune cells, particularly the microglia, which are the brain's natural cleaning cells, to remove these plaques from the brain. So by reducing the amount of amyloid presence, the medicines aim to slow the progression of Alzheimer's disease, especially when we begin this treatment early. So there are three main disease-modifying therapies currently attracting attention. We have aducanumab, lecanemab, or donanemab. So unlike the traditional Alzheimer's medicines, you have said these drugs are not available as tablets, and they are administered through IV infusions, especially in hospitals. They are marketed under brand names Aduhelm, Lukembi, or Kisunla. Although these medicines represent a major scientific breakthrough, it is also important to understand that they are not cures. And another important point, is that these therapies are currently recommended only for patients in the early stages of Alzheimer's disease, particularly those with mild cognitive impairment or mild dementia who have confirmed amyloid pathology. They are not appropriate for everyone who lives with the dementia. These treatments have generated a great deal of excitement because for the first time we're having diseases that attempt to modify the cause of Alzheimer's disease rather than just symptoms. However, they also come with very important safety consideration and careful patient selection, regularly monitoring, which we'll discuss in the next slides. So let us begin by looking at the first of these therapies, aducanumab, including how it works and the important safety considerations. So aducanumab made history because it was the first medication approved that specifically targeted one of the underlying causes of Alzheimer's. It belongs to the monoclonal antibodies, and so it has been engineered to recognize and attach to the abnormal beta amyloid plaques that build up in the brains of people who have Alzheimer's. So once the drug binds to these plaques, it helps activate the brain's natural immune cells, which we had mentioned, the microglia, to clear the plaques away. The goal is to reduce the amyloid accumulation and hopefully slow the progression of this disease. So unlike the medicines such as the donepezil or memantine, this one is an IV infusion, and treatment is usually given once every 4 weeks in a hospital. It is intended for people who have early stage Alzheimer's disease, particularly those who have mild cognitive impairment or mild dementia with confirmed amyloid plaques. So although aducanumab was a major milestone in Alzheimer's research, it has also been one of the most debated medicines in recent years. While it clearly reduces amyloid plaques, scientists and clinicians continue to discuss how much this translates into meaningful improvement in patients' daily lives. Even so, it has opened up the door for newer therapies that followed and marked the beginning of a completely new direction in the Alzheimer's treatment. So like all powerful medicines, it has also come with important safety concerns. So, and one of the most important things here we're looking at with this medicine is that it causes a condition called ARIA, which stands for amyloid-related imaging abnormalities. This is because amyloid plaques are removed from the brain. Some blood vessels can temporarily become very fragile. And so we have two main types of ARIA. We have ARIA E, where the E stands for the edema, which means the swelling or fluid accumulation in the brain. While the second one is ARIA H, which stands for the hemorrhage, where we have tiny areas of bleeding or microbleeds within the brain. So many people who develop ARIA may have no symptoms at all, which is why we need regular MRI scans during the course of treatment. However, some patients may also experience headaches, dizziness, nausea, confusion, or visual disturbances. So as I had mentioned, aducanumab is not suitable for everyone, especially for people who have had severe allergic reactions to these medicines, who have had a history of brain hemorrhage, any recent strokes, or an extensive cerebral vascular disease are not good candidates. You also have people who have a ApoE4 gene, especially those who inherited it from the parents, also have a higher chance of getting ARIA. So genetics testing is very important before we begin this treatment. And researchers have continued improving this treatment approach, leading to the development of another medicine, which is called the lecanemab. Lecanemab, yes. So this is one of the newest. It is one of the newest and most promising treatments for early Alzheimer's disease. So it is also a monoclonal antibody, but it targets a slightly different form of the beta amyloid. Instead of mainly attaching to mature plaques, it preferentially binds to soluble amyloid protofibrils, which are believed to be very harmful during the early stages of the disease. So by removing these abnormal proteins before they form larger plaques, it aims to reduce the slow damage to the brain cells and preserve cognitive function. So it is also IV infusion every 2 weeks, and it is usually marketed under the brand name Leqembi. It is approved for patients with early Alzheimer's disease, including people with mild cognitive impairment. And so one of the reasons why this drug has attracted so much attention is because it demonstrated strong clinical evidence in the large Clarity AD trial. Patients receiving this medicine experience slower rate of cognitive and functional decline compared with those receiving the placebo. So while these improvements are modest rather than dramatic, they represent a meaningful progress because they help the patients maintain their independence for longer. And so for many experts, the lecanemab represents one of the most important advances in this Alzheimer's treatment. So it may have a very favorable, it appears to have a more favorable safety profile than aducanumab, but careful monitoring is still essential because it can also cause ARIA, just as we saw. The patients may also develop the same symptoms, headaches, dizziness, confusion, nausea, or problems with balance. Certain groups also may require additional caution. As we had said, the individuals carrying the APOE4 gene have a greater likelihood of developing ARIA. And so because of this, as we had said, regular MRI scans are very important for patients before and during treatment. Compared to aducanumab, it has very low rates of severe ARIA and strong evidence demonstrating clinical benefits. And so we move forward to the newest medicine in this group. This is donanemab, which uses a slightly different strategy to remove the amyloid from this brain. So, like the previous medications, it targets a unique form of beta amyloid called pyroglutamate modified amyloid, which is found mainly within the mature amyloid plaques. So when it attaches to these plaques, it helps the brain immune system remove them more efficiently. So it is given as IV infusion and marketed under the brand name Kisumla. And an interesting feature is that the treatment may not need to continue indefinitely as such. In some patients, therapy can be stopped once imaging shows that the amyloid levels have been reduced to a predetermined target by the physician and the care by the physicians. This is different from any other long-term treatments. Clinical trials show that it slowed cognitive decline in patients with early symptomatic Alzheimer's disease, providing another important option for carefully selected patients. But like other disease-modifying therapies, it is designed to slow disease progression and not really cure Alzheimer's. And because donanemab removes amyloid plaques very effectively, careful safety consideration is also required, particularly for ARIA, which remains of the most important adverse effects. Okay, so switching gears here, as dementia progresses, many patients may experience more than just memory loss. They may also develop what we call behavioral and psychological symptoms of dementia, BPSD. These symptoms include depression, anxiety, agitation, aggression, hallucinations, delusions, sleep disturbances. And so it is important to understand that most of these behaviors are not deliberate, they're part of the disease process. And it is very challenging for both the patient and their caregivers. Before using medication, healthcare professionals always try to identify the possible triggers. For example, pain, infections, constipations, dehydrations, and even unfamiliar surroundings can be triggers for these behavioral changes. And so when medicines are required, we generally divide them into three categories. The first group here we look at are the selective serotonin reuptake inhibitors, SSRIs. These medicines include sertraline, which is commonly sold as Zolofort. We have citalopram, which is marketed as Alexa, escitalopram marketed as Lexapro. So these medicines are used to treat depression and anxiety, which are very common in people living with dementia. They also work by increasing serotonin levels in the brain and help improve the mood and reduce emotional distress. So they are considered first choice medications when depression and anxiety is contributing to the behavioral symptoms. The second group, these are the antipsychotics. We have risperidone, ketapine, olanzapine. They are reserved for more severe situations such as hallucinations, delusions, severe aggression, agitation, that put the patients or other people at risk. However, they're not the first line treatments because they also increase the risk of stroke. They also have the excessive sedation and even can cause mortality in older adults. The final group, these are the sleep agents, anxiolytics. We have lorazepam, oxazepam, and melatonin. They help reduce anxiety and also improve the sleep, but they should be used cautiously because they can increase drowsiness, confusion, and the risk of falls. So the most important message from this slide is that medications are only one part of managing the behavioral symptoms. However possible, non-drug approaches such as maintaining familiar routine, providing reassurances, and ensuring a calm environment, and supporting caregivers should always be tried first. Back to you, Isha.
Thank you, Arthur. The shift toward disease modifying therapies is truly a paradigm shift in how we approach this condition. As we enter the final leg of our webinar, it's time to bring all of this clinical science directly to the patient's bedside and our local communities. I'd like to welcome our final speaker, Chisom Mary Ekwu. Chisom is going to guide us through critical special population considerations, such as navigating hepatic and renal impairment, as well as the ever-present challenge of polypharmacy in our elderly patients. Chisom will ground our discussion in our local context by examining the current landscape of dementia pharmacotherapy right here in Kenya, outlining the real-world challenges we face and the massive opportunities we have for improvement. Chisom, take it away.
Thank you so much, Esha. So I'll be taking you through special population consideration as well as other factors that we'll look at to round this presentation up. So now that we have covered the drugs, let's talk about the people who actually take them. In medicine, we have been taught many times that we don't just treat the disease, we treat also the person with the disease. And hence, of course, we have learned from my fellow colleagues, these patients hence need highly personalized care. Now, when we look at dementia, we often attribute it to older population. And while that is true for the majority, it can also affect people under the age bracket, under 65 years old, but it's very rare. But since the elderly patients tend to have more comorbidities, organ impairments, we tend to look at, and they are the most burdened, so we tend to look at them mostly. So of course, as they age, their brains even become more sensitive to these medications, hence they are at higher risk of being dizzy, confused, experiencing falls, of course increasing their fracture risk. And the way to go about this with these population would be to start slow and go slow, which just means that we have to start at the smallest possible dose and then maybe adjust or raise it as per needed, or as seen or as observed by the pharmacist. So of course, that aging aspect of it, the cells are undergoing what they call senescence, right? So these organs such as the liver, especially when we look at pharmacokinetic aspect, the liver and the kidney play a very important role. And in the elderly patients, we'll see that they have now they are not working as well as they would in the prime age of these patients, of these elderly people. So of course, for example, that common drug memantine is cleared by the kidney. So if these are weak, of course, in this case, the elderly patients, they can't be as cleared as quickly as they would in a younger person. So you now find that they increase in the body, and of course toxicity and the side effects that come with the drug pose tends to show, become more expressed in the body of this elderly patient. Hepatic impairment, of course, if these drugs are not metabolized as they would be in a younger patient, they also build up. If just like even the kidney, if it's not cleared, if it's not metabolized into its one could say non-toxic form, it can also, even other metabolites that can be toxic, if it's not even cleared by the kidney, they can also increase in concentration, and hence also adverse effects can, show up. As for polypharmacy, of course, in elderly patients, they come with other, most of them come with other diseases, comorbidities, if you will, for lack of a better word. And these medications tend to increase the risk of dangerous side effects, and hence hospitalizations can occur in very severe cases. So the goal, of course, will now be to cut down on these unnecessary pills rather, and keep them as simple and as safe as possible. So moving to the next slide, the important prescribing pills, well, it would be for us pharmacists. I think when we look at that, we are trying to put in the best practices that can help these patients, to ensure their safety rather. And they can be divided, of course, into these three phases: before prescribing, before you write the prescription, when and during the treatment. So first of all, we need to rule out any other medical condition that can precipitate said symptoms, similar symptoms of dementia, right? So that, of course, you don't treat something else when it's another medical condition entirely. And we also have to look at the non-medication strategies, and it can be by also optimizing the patient's environment or changing their environment, really, to make them more active and engaged. It can even be as like educating their caregivers. We know that elderly patients tend to have caregivers, maybe even as relatives or as people that are hired, so as to ensure adherence and prevent suboptimal therapy. So when prescribing, the main thing would be to just take it, of course, as I've said, we take it slow. We change one medication at a time, and we pinpoint, of course, what is working, what is not, what side effects are evolving, because the patients are different. And during treatment, of course, regular monitoring that's non-negotiable. So you assess the efficacy, the adverse effects, and all that, so as to reassess whether or not you want to swap for an alternative or to discontinue when you see that there's no point to administer that medication. So what we try to avoid, because of the high risk of side effects from certain medications, would be anticholinergic drugs, because some medications, of course, with the anticholinergic properties, they block certain brain chemical pathways and can actually worsen dementia symptoms. The same with certain antipsychotics. Of course, those ones have to be minimized. We can't eliminate their use. And we have to avoid also prolonged antipsychotic therapy. But I think one of the main things that we can also look at would be polypharmacy. As I've said, during treatments, we try to cut away those medications that are unnecessary, tailor them to the patient's needs and comorbidities and such. Next slide, please. So dementia pharmacotherapy in Kenya. The current situation, okay, so we know that the elderly population are the most affected and there is a rising burden. This could be due to reduced or less lack of awareness. This could also be due to limited access to health facilities, to certain specialists. And these are real challenges, of course, that contribute to this population increasing steadily also with time. So what do we do to mitigate this? We provide awareness through education. We create or integrate the primary like healthcare facilities for earlier screening and diagnosis. Of course, we improve medicine availability, and of course, with technology, we can implement digital health and telemedicine so that the patient or the caregiver can reach these specialists even from a remote area. So our take-home messages, now that we understand dementia, we can say that it's a progressive condition. Alzheimer's disease being the most common root cause, and this thing requires us to see it as a memory decline, as we have said on and on again, and we must consider also the emotional state of these patients, as well as, of course, their family, their relatives, and the pharmacotherapy. Of course, we noting that acetylcholinesterase inhibitors remain the first line for defense, and the newer disease modifying therapies, of course, offer this exciting new hope to improve the quality of life and, of course, even maximize cognition. We also need to note the safety of the patients, as there is need for aggressive monitoring. We want to avoid high risk drugs that can cloud or overwhelm the signaling of the brain. And last but not least, the patient-centered care needs to be individualized. Of course, the patient is like the pharmaceutical care plan, of course, it needs to be individualized for the patient, provision for support and empowerment for even the caregivers and the family of the patient. So thank you very much for listening. I'll hand it back over to my colleague Esha.
Wow, amazing. Thank you, Chisom, for that incredibly insightful breakdown. Bringing this back to our local context here in Kenya and highlighting those practical take-home messages is exactly what we need to improve patient-centered care. This brings us to the end of our webinar. I want to extend a massive thank you to our brilliant speakers today, Bernice, Arthur, and Chisom. You have all done a phenomenal job breaking down complex clinical data. And once again, a huge thank you to Dr. Amias Terefe for empowering us to take this knowledge and share it as digital health communicators. To our audience, thank you for your time and attention. We will now open the floor. If you have any questions for us, please drop them in the chat, or you can use the raise hand feature. Thank you, everyone. Thank you. Dr. Amius, would you like to say anything?
No, I have nothing to say, but just to say thank you. Well done. You have really done quite excellently. Thank you.
Thank you, sir.